Welcome back to our business interview, 4DMed Update. Joining us for another exciting update is the director of the company, Dr. Neville Shimmin. Welcome back to the show.
Hi Andy, it's great to be back and I'm looking forward to the interview.
What events has 4DMed been involved in recently?
Well Andy, we've attended the VR4 Rehab conference that was on the 24th to the 26th of June. And there was some fascinating and interesting information that was provided there during the conference meetings. One of them was pediatric care and how VR glasses are being used to help children walk again. Because after they fractured their limbs, they're very fearful of applying pressure to that limb that was damaged. So the VR headset simulates a fully recovered and healthy foot so that the patient is no longer fearful of applying pressure to their leg and they can begin to learn to walk again much faster. Another very interesting company that was presenting information there showed how an individual who'd had back surgery could then go back to the physician and identify any pains or problems that they were having post-surgery. So what happened was the doctor could wear a VR headset, there would be a template of the patient's body presented to him, and the patient could then point to the site that was injured, and the surgeon could then place their hands and palpate the site of injury, and immediately the 3D MRI scan would appear. So they could look internally and localize where the injury was now presenting itself or the pain, and look to see whether it was close to the site of surgery or close to any other injury of the past. So it was very, very useful for both the patient and the doctor to be able to visualize the pain that's associated post-surgery or whether it was a new pain. One of the other very, very interesting presentations there was to do with what we call laparoscopic surgery. So traditionally, laparoscopic surgery has many different labels. Some call it keyhole surgery or minimally invasive surgery. But basically, you insert a tube into the abdomen and there's a camera attached. And a surgeon looks through this camera at a computer screen and uses his hands and another apparatus to perform surgical procedures. Now, typically, the surgeon is looking at a big monitor, not at their hands, and that makes the whole process much harder. Now with a VR headset, the surgeon can look directly at their hands and yet perform the surgery as if they're doing it manually, because the information from the camera is being directly to the headset. Now the wonderful thing about this was this feature called interoperability. That means on the right eye, the doctor was receiving information from the camera and the surgery that they're currently doing. On the left eye, they were receiving images from the previous surgery or when they previously did a scope or a laparoscopic procedure, so they could compare the same sites at different times. This is fantastic for the surgeon to see whether there's been any deviations or abnormalities since the last surgery. And on top of that, on the bottom of the screen, all the important physiological parameters or critical care parameters are also being placed in the surgeon's or the doctor's field of view, so they can keep an eye on multiple aspects of information at the same time, and then be able to immediately query with the nurse anything that looks abnormal. I thought this was a tremendous feature and really empowers the surgeon or the doctor to have far more information directly to hand. The final other point to this particular procedure was information or digital data from IoT-enabled surgical equipment was being beamed directly to the surgeon, bypassing all the nurses. So the surgeon could take direct control of the information displayed to him, whatever he felt was critical and important to them. We feel this feature we're going to incorporate in our own simulations, because this is going to be the future of surgery, where you have this interoperability and IoT digital data being fed from surgical equipment directly to the surgeon so that they can be kept in the best situational awareness scenario.
Besides this exciting development, are there any other recent advancements?
Absolutely, Andy. I think we've all looked very carefully at this COVID pandemic situation, and many hospitals now are creating annexes or facilities attached to the side of the hospital that are isolated away from the main units to handle COVID-19 patients. So typically when we create a scenario, it's based on the Society for Academic Medicine's Emergency Medicine's open source case model. So you have a scenario, then there's certain inputs, there could be something happen performed by the doctors or the nurses, and then it leads to another scenario and another layer or an outcome and so forth. So we use that particular model to create a scenario for this particular pandemic. So we're looking to create or simulate an annex or an isolated ward that's attached to the side of a hospital, where the typical layout of an accident emergency department is different. So what we've done is look to model this annex and its particular layout and the type of interactions doctors and nurses are going to have in there. So instead of the doctor being presented much later in a A&E scenario, because typically somebody would go to the check-in desk and then see a nurse, now the doctor or the nurse will be fully gowned up in fully isolated ward section, and the patient would immediately undergo a diagnostic test to confirm whether they're infected or not, then immediately take a series of blood tests, then go forth and see a doctor and immediately have a set of ECG tests or blood pressure tests to see whether they have this particular disease. All the other ancillary services, whether it be cardiology and so forth, are also in separate, closely contained units, which can be activated and brought in as and when needed. But the teams are much smaller and much more isolated, with digital information being presented through on-site equipment. So instead of relying on MRI units in the hospital, more basic equipment will be used like CT and X-ray to get an immediate clinical picture.
How are simulations becoming more realistic for teaching purposes?
I think that's a great question, Andy, and it really focuses on most simulations have been very static. I mean, hardware is being used extensively now with tensor imaging and also incorporation of lighting effects. That's one aspect of making the environment seem more realistic. But the actual simulations are often very static. You have a scenario, the doctor produces or the student produces an input, then there's an outcome and so forth. What the future is going to be and what we're trying to incorporate is the multiplayer aspect, where we incorporate a nurse, a real nurse within the scenario. We have another standing physician, and questions are being asked and interactions are occurring with the physician or the patient or the student who's learning. So the nurse may say, oh, do you want to use this instrument? What should we do next? Do you want to do this, doctor? So it's more interactive and more realistic, because to be immersive, it needs to be breaking away from that static model of input and output. There needs to be many different variables occurring, and that multiplayer scenario will do that. The other thing is that the student really needs some feedback in real time, so the reporting tools need to be able to indicate to the student what they're doing right and what potentially they should be paying more closer attention to, because the scenario is leading them into a negative aspect.
What are the challenges in creating an immersive training scenario?
The student needs to feel the necessity to act in a logical way, but with time constraints. So you need to create this element of the situation is evolving, and any delay in communication between other ancillary staff there, whether it be nurses or asking for a consultation from somebody else, will lead to a negative outcome. And to force the student to anticipate that they need to have other clinical information or seek other clinical information to resolve this problem that's in front of them. So we're trying to create scenarios where, again, it's not static, but the student has to use their clinical insight, has to use their clinical education training to make decisions far quicker and far more logically.
How will 4DMed use the new technology to improve simulations and the learning experience?
I think, as previously mentioned, Andy, we want to incorporate powerful reporting tools. So when the student is making decisions and looking to seek information, that they are guided into perhaps understanding what should be the primary information line or decision tree that they should be following, and what is going right in this scenario now and what is going wrong. What perhaps should they be doing faster or seeking to be able to make the next clinical judgment, and what to anticipate after they've made that clinical judgment.
Well, it seems like technology continues to advance at a rapid pace, and I'd like to thank you again for joining us on the program today.
That's awesome. Thank you, Andy, and thank you for your time.
And that is our show for today. Stay tuned for more exciting news in the near future. Thanks for watching. See you next time.